Hello, ladies and gentlemen, dear colleagues. It's really a pleasure to have you online for this important session on complex coronary interventions that will be helped by a new device that will be demonstrated by different colleagues all across the world, coming from Malaysia, coming from Turkey. I am from Mons in Belgium. It's morning for me, and it's really a pleasure to start this seminar. I will have the pleasure to be opening this, and I will have as a speaker, we will have Dr. Hafidz bin Hadi from Malaysia. He's a consultant cardiologist from National Heart Institute in Malaysia. He is a member of the Royal College of Physicians of the United Kingdom, and is also a member of the National Heart Association of Malaysia. Next. We also have with us Professor Cüneyt Koçaş. He is professor of cardiology and an interventional cardiologist in the Biruni University Hospital. He is a fellow of the Society of Cardiovascular Angiography and Intervention, and a true member of a cherished society for me, the Turkish Society of Cardiology. The president is a very good friend of mine, Dr. Muzaffer de Gertekin. He is also Professor Koçaş, a member of the European Society of Cardiology. And the next speaker will be Dr. Dan Ioanes. He's coming from Sweden, so this is also morning for him. And he's a senior consultant cardiologist in the Sahlgrenska University Hospital in Gothenburg, Sweden. He's a member of the working group on PCI and valve intervention of the Swedish Society of Cardiology, and a full member of the EuroCTO Club. So we will have the pleasure to meet next week in Rotterdam. And finally, we have Professor Scott Harding from New Zealand. This is late in the evening for him. He's the director of the Cardiology Research Group and an interventional cardiologist in the Wellington Hospital in New Zealand. He has more than 100 publications in subject in cardiology and mainly interventional cardiology. And he is the past chairman of the New Zealand Interventional Group. And I thank you very much for him to be late, still up with us. This seminar will be organized, and I want to thank the company Brosmet for putting this together. This is going to be important to share our expertise with this new innovative blades that they put on the RevoEdge high pressure cutting balloon. And I have the pleasure to start presenting you how we could optimally prepare in a few patients. We are using the system now for a couple of months in complex coronary lesion. And this is a few cases that I want to share from Belgium. This will be, so we have seen the next talk will be with Professor Hafidz bin Hadi. Then we will have Professor Cüneyt, Dr. Dan Ioanes, and Professor Scott Harding. He will show also many important problems in his daily life with those very calcified lesions, where we really have to prepare and be able, if we want to have an optimal preparation of the lesion, in order to avoid some underdeployment, to avoid rupture of balloons, we have to deal with calcium. And you know that this calcium is everywhere and is making our life a bit difficult. We are like in jail, spending our time in the cath lab breaking rocks. And luckily, we have different devices that have been out in order to better prepare these calcified lesions. And there are several systems that have been described with some wires where the stress on the calcified spot is much increased, and this is going to break more easily those calcified lesions. There are many systems out there. It is very interesting to use a scoring or cutting balloons in complex lesion because you can get controlled dissections, which is going to be possible with either systems that are scoring. There are wires with one or multiple wires that you see are more or less smaller than a normal workhorse wire, like a BMW. Please remember, this is 1/3 of a millimeter. You have the known cutting balloon, the Wolverine, that is a stiff blade that will be just attached to the balloon, and that might impede the profile and also the flexibility and the deliverability. What is very interesting in the RevoEdge, those are the nitinol blades that are just 210 micron thick and that are really going to cut in the plaque, but they are also going to be free from the balloon itself. And it's going to be, and you will see in a different example in this webinar, that it allows us to cross very challenging lesion. But let's go to one interesting case. This is a gentleman with many risk factors. He has preserved ejection fraction and inferior ischemia on a butamine test. He got a coronary CT, and we saw that there was severe calcification. And this is the angiogram of this gentleman, showing the right coronary artery with very tortuous segment 2 and calcification at that level. There is also some disease for the proximal LAD. Finally, the FFR was positive in the LAD, was negative in the circ. And the very first attempt to do this was with my colleague who put a 6 French radial cross with a BMW and try to open this lesion with a couple of semi-compliant balloon. But you see that the results are suboptimal. And finally, he was trying to use another scoring balloon, the Naviscore, and he couldn't really cross the lesion. He couldn't do anything. And he finished the procedure, leaving me this job for the next week, asking me, after failing 2 times with a scoring balloon, to consider making a rotablator procedure. Actually, I went with a 7 French radial, and the very first thing that I did was to cross the lesion with an IVUS in order to understand what was happening. And we can see that there were really important calcified nodules and tortuosity and nearly 360 degrees of calcium there. So it was necessary to perhaps have a better support, but also a better scoring balloon. And instead of taking straight a rotablator, I went for a predilatation, advancing a guideliner with a non-compliant 3.0 Apollo, and then I could advance, and you see this system advancing very nicely, supported by the 6 French extension guiding guideliner, the RevoEdge 3.0, that is opening quite nicely the lesion, and you see that in this IVUS that is performed, we see cracks and we see fracture in the calcium. So that lesion is then optimally prepared in order to just advance a long Megatron 3.5 that, based on the IVUS measurement, we could safely post-dilate up to a 4.0 with a non-compliant Apollo balloon. And you see that the minimum lumen area obtained in the stent is well above the distal reference where there was still some disease, but you will consider this as an optimal result with some remaining outside of the vessel, outside of the stent, some lesion. That's another interesting case I wanted to share with you. Complicated patients with already a pericardiotomy for restrictive pericarditis. He has a pacemaker, he has a preserved ejection fraction. And he had a couple of PCI already in 2022. And December last year, he was readmitted with a restenosis and subocclusion of this right coronary artery. This is the lesion that we face for now this summer. This is a very tricky LED lesion with tortuosity, and you see a very large burden of calcification. And even with a extension guide and two wires next to it, the non-compliant Apollo could not open nicely this lesion. And finally, my colleague tried to advance a lithotripsy balloon, but unfortunately, it never crossed the lesion and it could not advance this. So we have failed procedure with a shock wave. And once again, he asked me, could you consider making a rotablator in this one? But you see that basically that lesion has already some dissection, and I don't think that it would be a good idea to try to do a rotablator first. So we went for the RevoEdge, and you see that it crossed quite nicely, the 2.520. I could open the lesion at 20 atmosphere at several levels. After this, this is just conventional balloon angioplasty with a non-compliant additional 3.0. And then we advanced the Synergy 48 millimeter that we could also post-dilate, and proximally we could also post-dilate up to 3.5, this proximal stent that was present. And you will see the final result. We did some drug-coated balloon in the proximal LED, and you see that we have quite a nice results at this level. So two failed attempts of preparing calcified lesion, one with a scoring balloon, one with lithotripsy. Actually, this first case is also the third case that I did with ever the RevoEdge. This is a patient known with peripheral arterial disease. He's seen preoperatively, and we find basically this problem on the very proximal LED. It's nearly occluded, it's heavily calcified and very tortuous. As you can see, there is some collaterals already filling from the right side. And in this kind of circumstance, I think it's very important to treat these patients like a CTO and go with double access procedure, go with a microcatheter. And finally, we were lucky to cross with just a cyan blue. We did some predilatation with a R times 2.0. And after this, actually, I wanted to check, and you always have this appearance of the RevoEdge. So there is a distal marker, and then you will cut in between the two proximal markers that you see. The balloon is advancing without even a supportive extension catheter, and we could open this nearly CTO vessel and very calcified lesion that was further after this treated. We put an angiolite, we perform an IVUS. With this IVUS, we could see that basically there was just distal to the stent still important stenosis that we could not leave like this. And finally, after an additional stent, this is the let me try to advance to the next slide. Oh, I just think that I lost the last. Are you still with me? I got some problems with this. So this seems to be blocked. I saw the patient yesterday, by the way, and he's doing very fine, and he's doing much better than the PowerPoint presentation that is now being stuck. I don't know exactly what is happening on this side. I will have to close this. And if I am then with these technical problems, I will perhaps try to jump to perhaps the conclusion that I wanted to share with you, because I need to try again. So sorry for this delay. I had another case that we were performing in a proximal LED, and with the same RevoEdge, we were going to a second circ to treat also, because honestly, there is an excellent profile and crossability, but it is also possible to reuse multiple times this new RevoEdge in challenging calcified lesion. We can treat effectively lesion that has been failed by other approach. I show you failed scoring balloon or lithotripsy. And of course, it remains important to understand what is happening in these challenging lesion with intravascular imaging. We can see cracks, we can see optimal preparation, and this allows us to go for some hybrid strategy, sometimes combining drug-coated balloons and stenting. In our limited experience, I must say that the RevoEdge keeps a very good profile, and we can use it multiple times in a multi-vessel complex CHIP procedure. I don't know if my colleagues would like now to comment on this case and if they have any questions so far. The floor is open, dear colleagues, to your remarks, your suggestion to improve our experience of the RevoEdge in Mons based on your own experience. You can unmute your microphone and
Professor Carlier, Hafidz
yes,
from Malaysia. Hi. Yeah. Sorry. It was a great case sharing your cases. You got a lot of experience using a RevoEdge in your complex calcified lesions. My experience is very limited, but I'll just share with the case. But do you believe that RevoEdge may actually, do you feel that RevoEdge may actually replace a debulking device, or you think it's more of a complementary function in terms of plug modifications?
you know, the algorithm says that if you do not cross a lesion with an IVUS catheter, you should already consider some rod ablation. And the last case that I had that crash, but this is a case where I could not cross with the IVUS, a proximal LED lesion, and yet I could cross with the RevoEdge. So if you consider the two options, of course, it's a very tight, subocclusive, calcified lesion. You might not really be able to replace a rod ablator. That remains the best approach for this. But if you look at the price, the difference, one of the main advantage of the RevoEdge for me is also once you cross, actually you can go to a high pressure. You can go all the way up to 20 atmosphere. The other cutting balloon that I know is only limited normally to 8 to 10 atmosphere, even if some publications you find that they are going well above this recommended pressure. So I will not say ever that it will replace rod ablation, but it's a nice complementary tool for those lesions where other device cannot cross, even your IVUS. And my limited experience, that's just now 4 months that we are using it, so it's still also limited. But I try it in complex lesion, because you know that this is the best way to go and to understand where the device will be limited, is to push it. And you saw the third case is really the third case, the third RevoEdge I had in my hands, and I chose that crazy proximal tortuous LED, and it went through, and it really helped.
Yeah, I think the good thing about this RevoEdge, despite it being a cutting balloon itself, it's very maneuverable in tortuous lesions. So I think that's one of the plus point that we find that RevoEdge is effective.
So I think that if there are no other questions, so do you have some comments, Dr. Kokas?
Yeah, Stefan, I want to ask you a question. Yes, we have tried RevoEdge in many cases, but as you know, you can go up to 20 atmospheres with this balloon. Maybe it's one of the biggest advantages compared to Wolverine and the others. But I don't remember that I have gone up to that atmospheres. Have you tried RevoEdge with that high pressures? Did you need it? Because in my experience, I think 10-20 atmospheres were enough for most of our cases. I didn't need to go that up high. Have you tried it?
Yes,
And do you think
that's exactly one of the main advantage, and you see that this is in some circumstances really the pressure is multiplied by a factor of 3 at the level of the cutting elements. This is the wire. You can have 3 now around your balloon cutting elements that are very thin still. So you do precise just plaque preparation. You don't get those very long dissection distal if you use a very high pressure balloon in an uncontrolled fashion. And really, you avoid also the slippery effect by using the system. So without any balloon slipping in the lesion, you can go all the way quite high. It's not necessary to go to 20 atmosphere every time, but if you still see some dog boning on your balloon, I will not hesitate to go all the way up to 20. But of course, you have to size this carefully, and it helps to have all the tools possible, also intravascular imaging when you can. Not all the cases you have seen were done with IVUS, but it will also help.
Just make a comment.
Sure.
So we quite often use up to 20 atmospheres, and particularly in stent restenosis, it's very safe to go to high pressure, and often you want to cut, but also expand. So I think in stent restenosis, the ability to go to 20 atmospheres is very, very helpful, as well as calcified lesions.
And what about in that indication? Yes, it's not recommended to use it in newly implanted stents, but sometimes it happens. You implant a stent and it is not opened. You cannot open it, expand it very well. Do you think can we try it in that options? In that cases, we implant a stent and it's not opened well. You should try it. No,
I don't think so. Because cutting will not work, outside the stent, and that's usually a calcium outside the stent problem, right?
Yeah,
exactly. I would not go for using the dead balloon. We have other tools, and once all the stents are in place, and we can use very high pressure balloon. We can use if really necessary, if you see a problem. But what we do is looking at the balloon open, high pressure, and do a stent boost in 2 views. We see nicely actually the cutting blades, and we also can appreciate all the burden of the calcium in the vessel wall, and if really there is an extension. I would not go for any stenting if I don't see the balloon really nicely open. So if there are no further questions or comment, I think this is time perhaps that we hear the experience of Dr. Hafidz bin Hadi, and I look forward for your difficulties with the RevoEdge solving them.
Hi, hi everyone. Thank you very much. First of all, it's truly an honor to be here among the expert panels, and also thank you, Prof, for actually inviting me here to share with you a case of mine using a RevoEdge. RevoEdge is relatively new in Malaysia, and my experience is very limited, but probably I'll just share with you, maybe ask your opinions and comments regarding the case, which I'd like to share. So I think as a background, we know that basically RevoEdge is actually the background itself. PCI is becoming more and more complex, and this is as a result of aging population and patients having multiple comorbidities. And the challenges is actually addressing the calcified and fibrotic lesions, because lesions becoming more and more difficult. You have difficulty to bring the devices into the affected site, and this may impact your stent delivery and stent performance, and thus affects the patient's outcomes. So a normal standard balloon angioplasty will not be able to address fibrotic or calcified plaques, hence poor lesion preparations. And in fact, if you go even high pressures, so you may end up having dissections and perforation as a result of the barotrauma. So with the RevoEdge itself, I think have already been addressed by Professor Carlier. The benefit of the RevoEdge here is that it's an NC balloon. And furthermore, you can increase the pressures up to 20 atmosphere. And you know that the plates are actually not on the balloon itself, but actually been welded at both the proximal as well as the distal end of the balloon. And with this design allows the balloon to become more trackable compared to its competitor in the market. So, there are various indications to use a cutting balloon. I think probably will be emphasized by the other speakers itself. But basically, it can be used for in-stent restenosis, bifurcation lesions, calcified lesions, fibrotics, diffuse, as well as small vessel disease. And going back to probably for malposition or malexpansion for stents, I think it may not be suitable for those cases. But sharing with the case, I have a 49-year-old gentleman with a background history of hyperlipidemia, hypertension, and diabetes mellitus. And he presented initially with a history of inferior MI on the 4th of November 2024, last year, with a successful thrombolysis. Relevant investigation showing ECG having Q wave and T inversion and inferior leads, normal kidney functions, HbA1c 6.5, LDL 2.1 with an EF of 50 to 55%. So this is coronary angiogram findings. On the left-hand side, you can see a severe stenosis at the mid segment, of which a hybrid strategy was done with the DAS at the mid RCA and DCB at the distal RCA, with the 3533 DAS and the DCB 3030. And the right-hand side is the final results. So, we decided to do a stage PCI on the LED. So you can see that the circumflex here, not much of a disease, but from the proximal all the way to the mid segment of the LED, there is diffuse severe stenosis with calcifications. The shadowing may not be appears apparent, but I'll probably show you the IVUS images so you can appreciate better in terms of the calcifications. So this is the calcification from the mid all the way to the proximal LED to the left main. You can see a circumferential calcifications more than 3 quadrants, and the length is definitely more than 5 mm. So with this presence of calcifications, definitely it requires some sort of a plug modification or calcium modifying device. So if you look at the scoring system based on the IVUS, fulfill a circumferential calcifications, length of more than 270 of calcium, and also a diameter. The vessel diameter size is about 3.0 basically, and there's no vessel calcium nodules. So the point is 3. So if you look at the IVUS calcium score, this suggestion would be suitable for a lithotripsy balloon rotation. Either you can choose a rotational atherectomy or orbital atherectomy. However, in this case, we had the opportunity to use the RevoEdge. So we wanted to push the boundaries of the RevoEdge, how far it can be used. So this is the vessel size from the left main, proximal LED, mid LED, as well as the distal LED. So initially pre-dilated with a SC balloon 2.5 and 2.0 and 2.5/15, addressing the distal, mid, and the proximal segment. You can see some dark molding effect at the proximal LED. And this is the RevoEdge. I didn't get the picture of how the RevoEdge actually passed down smoothly into the LED. I think it's quite straightforward, but definitely if you do not have a lesion preparation, you may not be able to bring down a cutting balloon, the other cutting balloon. For RevoEdge, it went up very smoothly. So just to show you the unique features of the RevoEdge here, you can see that it has 3 markers, 2 on the balloon and 1 that's close to the distal tip. So this is one of the things, the uniqueness about the RevoEdge itself, distinctive from the other balloons. So you can see that there's some slight wasting of the balloon, and we actually, in this case, we actually push up the boundaries, exceeding the RPPM up to 24. I know it's not something that you recommend, but we tried to push the limit, and finally we managed to open up with multiple balloon inflations. 3015 addressing at the mid proximal as well as the left main itself. And this is the vessel preparation after we also further predilate with the NC at the proximal segment, because the size was about 3.5. So we predilated the proximal segment with the 3.5/15, and this was the final results after the vessel preparation. So hence, after looking at the vessel preparation, we decided to put the DES stent at the proximal LED, 3038. And then also we decided to go with the left main stenting because the left main was also, the opposite LED was involved. So DES 3533 from the left main to the proximal LED. And after that, we actually use a pod balloon. Pod balloon is a balloon also by Brosmet, suitable to address, because of the short shoulder itself, suitable to address for distal left main to address the POC area. So POC pod with a 456 at the distal end of the left main. And then also we subsequently post-dilated the vessel with the 3.5/15 and re-pod it again with a 456. So we also, because of the distal segment, there was some disease there. We DCB'd the distal LED with the 2.5/15. And this is the IVUS image after we implanted the stent. So you can see that after a good vessel preparation, the stent appears to be well expanded, well opposed to the wall. There's no stent edge dissections, so it's opened up quite nicely. You can see that the ostium is a bit malopose, so we did report again, and then we accepted the results. So this is the final image that after doing the case, you can see that the left main is quite open. The sub is still preserved, and the proximal and mid LED, you can see the stent is opened up quite nicely on the images. So with the MSA itself, all above 5, you can see at the distal 6.3, proximal, mid to proximal is about 7 to 9, and then left main is at 14 mm squared. So you can compare the images before and after the PCI. You can see how bad the vessel was before we put the stents, and after we put the stent, and with the RevoEdge having a good vessel preparation, particularly on a calcified lesion, you can see that the stents appears to be very well open up the vessel. So I think in summary, RevoEdge is a novel cutting balloon designed particularly for not only fibrotic but for calcified coronary lesions. With the blade itself, allow you to have a controlled dissection and allow you to have a good plug modifications. Because of the NC feature itself, it provides a safer, more predictable option compared to your other balloons. And with this, with a good vessel preparation, you may help to have a good stent delivery and expansion, and thus improving the patient's outcomes. Thank you for your kind attention.
This is really a great case, and it shows how a combination of safe, very high pressure can be obtained once you know the size of the vessel. And I think combining in this complex PCI intravascular imaging and this kind of precise high pressure cutting balloon, this is very key to obtain such a nice success. I don't know if Dr. Harding want to add something on your conclusion on the restenosis.
Yeah, I mean, I think it was a beautiful case. The IVUS was very interesting because it was actually pretty heavily calcified and over quite a long segment, certainly some 360 degrees of calcium. So it's sort of definitely pushing the limits of balloon dilatation. So and you could see that you went to 24 atmospheres before it went. And I think, you know, the sizing is key here. It is, because if you're going to go to that high pressure, you don't want to oversize the balloon. And, you know, the imaging really was very helpful in that way. So it was a beautifully done case. And as I say, it's not infrequently that we go to high pressures, even calcified lesions, but I image 100% in my case. So every case we do, we image. So we use that to guide.
I think that's a key message, and this is also why finally the American and the European guidelines are promoting now the usage of intravascular imaging as a class 1A indication. Not for all the case, and I wouldn't say that we have to treat all the coronary stenosis with a cutting balloon, but really this makes the complex PCI, and that's what is recommended in the guidelines. A bifurcation, a long lesion, a very calcified, a left main, all these indications are supported by intravascular imaging with less stent thrombosis, with actually even a decrease in mortality. So this is a key, and one of the remaining issue, of course, all across the globe is to be able to pay for this kind of more expensive device, the cutting balloon, as well as the intravascular imaging. But when you rupture, when you get the patient going to surgery, because you were not able to assess that there was some negative remodeling and that you push your luck and unsafely go to very high pressure with a too big balloon, this also has a cost for all your hospital and for all your economy. So I think that there should be an understanding that by doing a more precise complex PCI, we are also saving life and saving money down the road. I don't know, what is your experience in Turkey, in Istanbul? Can you easily get all these devices now reimbursed?
Yeah, in Turkey it's a bit complicated. Everything is reimbursed, but the reimbursed prices are so low. So in private hospitals, mostly the patients have to compensate some of the interventions like IVUS or for some of the cutting balloons. But in state hospitals, patients do not have to give any compensation, but you cannot reach all the best devices. So yes, we have some shortage of reimbursement problem in most of the cases, unfortunately. I just want to maybe add a comment for Dr. Hadi's case. It was a perfect case. Congratulations. Maybe I have seen it in some cases, instead of going up to very high pressures in one go, repeated lower inflations, lower pressures may also help to open that Doppler effect. Maybe 12 atmosphere one, deflate and inflate again for 14 atmospheres. And by this way, maybe you can skip going up to that high atmospheres. Yeah, we know it's safe, but you are pushing the boundaries, as you know.
Yeah. I would agree with Dr. Koçaş. Yeah. So it's a multiple balloon inflation in order to open up the vessel. Definitely is what we did actually.
Can I just make a comment? I think you were talking about costs, but what we've found is by imaging a lot of these things, we actually use more balloon and less atherectomy and less shockwave, because what we've learned from, for example, the CLIPS trial, is that angiography is not a good way to choose your tool. So what appeared to be heavily calcified lesions in the Eclipse trial actually did very well with standard balloon dilatation. And so I think sometimes if we use just an angiographic approach, we can overuse atherectomy or shockwave. And obviously, we can test things with a balloon. That's one way of doing it. But intravascular imaging gives us a very good idea of what we can potentially treat with cheaper devices and potentially safer devices. So, and as I say, we've got trial evidence for that. The Calypso trial was randomized to imaging guidance versus angio guidance, showed you got a bigger MSA. We saw the sub-studies of Eclipse, which was OCT, and the sub-study of Illumin-4 both showed a major benefit for imaging in terms of outcomes in calcified lesions. So I just, wanted to put up my hand and say that.
Yeah, that's a very important point, and I'm glad that you mentioned this because we were also running in Belgium a study with the ancestor of the RevoEdge. There was only one wire. The wedge balloon was tested versus a conventional balloon, and interestingly, down the road we were using less balloons in the arm with the wedge randomization than in the conventional arm. We had to use more non-compliant, high pressure before stenting. The crossability was somewhat better. I think that having one of the wire or the blade, now 3 blade, make the profile and the balloon go sometime actually easier. I don't know, what is your experience for crossing with a non-compliant balloon? We know them, some are not always very easy to reach distal tortuous arteries, and those non-compliant balloons are the only thing that we have if we don't have a cutting balloon. Do you have any experience or bad experience trying to get some non-compliant
I think everyone's had bad experience trying to deliver non-compliant balloons and calcified lesions. And certainly shockwave can be extremely difficult to deliver in the heavily calcified lesions, either getting it there or sometimes when you finally do manage to get it there, you've damaged the shockwave balloon, and then that's flushing a lot of money down the drain.
Yeah.
So at least my experience is that the RevoEdge, for a cutting balloon is extremely deliverable, and certainly far more deliverable than Wolverine, which is often quite difficult to deliver, and certainly not too different to non-compliant balloons. I wouldn't say it's superior, but I would say that it's pretty equivalent to a lot of the non-compliant balloons. That's been my experience. What's other people's experience?
I do face failure to cross with a RevoEdge, and I will take just R times 2.0 with an excellent profile or a 1.5, and then I will try again. That's for sure not a balloon that you will cross 100% of the lesion. This is that would not be fair to say that this is solving everything. But interestingly, if you go to a study with 5 different centers, friends that are very good operators, and we were not expecting to see less balloon use in a arm with some scoring element. That was the wedge, and that was a surprise. But when you think about it, it might actually help in some case to go down the road where you have to do the dilatation. But perhaps that Professor Koçaş has now some interesting case to show us about the crossability and his experience in Istanbul. It's for me really a pleasure to ask him now to share his experience during this webinar.
Thank you, Dr. Carlier. It's my pleasure to be here. But first, I think Dr. Hadi must turn off the presentation because I cannot share my screen. Yeah, I think I can share it. Can you see the presentation?
We see
Yeah, we can
Okay,
see
the PowerPoint.
Yeah, I think
Yeah,
it's fine now. Okay. Thank you for this chance to share my experiences about the RevoEdge cutting balloon, a new one. Yes, we all are facing with the calcified lesions these days. The population is getting older, and patients mostly don't want to be operated, and so we have to solve their problems in our cath labs, and we are using rotablation, orbital atherectomy, IVL, scoring and cutting balloons, super high pressure balloons, and non-compliance balloons for these indications. And we know from a meta-analysis that the cutting and scoring balloons are fine, they are safe and effective for indication for calcified. And if you look closer just for the cutting balloons, they are giving you a bit more minimal stent areas compared to other ones. I think I should just give a brief information because Dr. Hadi and Dr. Carlier give you a detailed information about the RevoEdge. My general impression is it's a hybrid balloon. It's a cutting balloon, it's an NC balloon, it's also a scoring balloon. It gives you lots of advantages of a cutting balloon, but at the same time, you can cross the lesions in the easy way. Cutting elements are taller compared to Wolverine. I think we should compare it to Wolverine because it's one of the most favorite balloons in the market in the cutting balloons, and the cutting elements are tall. A better crossing profile, the thinner balloon, and gives you the advantage of going very high pressures. And I think one of the most advantages of the RevoEdge is it is giving you a variety of size options. It is starting from 1.5 to 4.0, and the length is going up to 20 millimeters. When you are dealing with very diffuse lesions, I think it's a very big advantage. And we have a small trial comparing the Wolverine and the RevoEdge, and it is, yeah, it's I understand it's a small one, 168 patients, but it shows us that RevoEdge is as effective and safe as the Wolverine. I think I should directly jump into my cases because most of these informations are coming from the company sites, but the important thing is when you are dealing with a new device, what is your experience? It will show us how we will use these devices in our daily practice. This is an elevated proximal lesion. It's a long lesion, diffuse lesion. It's very calcified. Even you can understand from angiography, but we always do IVUS for these complex cases. We are looking for that calcium. Also, we are checking of the ostium of the LAD and the left vein if we need some other treatments. And as you see from the right panel from the IVUS, we have a circular calcification nearly through all the proximal LAD and it's extending to the left main. In that case, we wanted to try first the rota. We started with a 1.5 rota burr, and as you saw, it crossed easily, but it wouldn't be enough for that case. I will show you from the IVUS images. In the proximal passivate, yes, we had some cracks, but we felt that it wouldn't be enough to put a stent at that time, and we took 3.0 RevoEdge balloon, and afterwards, we had the IVUS again from the distal parts, and we still had some calcium, but you will see that nearly in all the parts, we had some cracks, and we felt that at this time, we could implant our stent, and we implanted a left main stent from left main to LAD, and we did a port, and this is the final result. As you see, the stent was well opened, it was perfectly opened, and we didn't see any malposition even in the IVUS. In this very complex case, RevoEdge helped us a lot to treat this complex vessel. The second case is an RCA CTO. As you see, it's a distal RCA CTO. It's not that long CTO. We crossed the CTO easily with the help of a microcatheter and NRIP CTO. It's a new one, but it is not that complex case, we could easily get to the distal. We checked from 2 projections, and we advanced our microcatheter. Nearly in all CTOs, we tried to advance our microcatheter distally, both for changing our wire and also modifying the plug. We were in the distal. And but the wire was in the PL branch, and also we wanted to save the PD branch. PD was also a very, very big branch. This was why we used a double lumen microcatheter to reach for the distal PD. You will see it now. We took the second wire to reach to the PD. Yeah, it's coming now. Yeah. Now we have 2 workhorse wires in the distal, in the PD and the PL. And the rest of the thing was just a ballooning for the distal parts with 2 or 30 balloons for the distal parts. For the proximal RCA, we had some calcium, and we wanted to be sure about to opening that part, and we took 3 or 20 RevoEdge balloon, and we inflated it. And there is one thing about the RevoEdge and the other cutting balloons. If you have 2 wires, in that case, you should be a bit carefully not to twist the wires. It can happen, but in this case, nothing happened, and we implanted our stent here. And as you see, the result is perfect. The stent was well opposed. There is no malopposition, and we could finish this case perfectly with the help of the RevoEdge balloon. The third case is a bit more complex case. It's an ISR case. There is a stent in the right coronary artery, the stenosis. We have a restenosis, and the problem was we couldn't even engage the right coronary artery well. We tried anchor ballooning for the branch, but it didn't give us a very good stability. And in that case, we changed our strategy and we took a guide extension catheter. Our guiding catheter was 6 branch, and our guide extension was also 6 branch. And from these things, we could easily advance 3 or RevoEdge balloon. The compatibility of new devices are also important, and we test RevoEdge cutting balloon in the scenario. We could easily advance it from the 6 branch guide extension catheter, and we inflate it in the proximal part without the help of the other balloons. It could easily cross that part, and as you see, we had a final good result in this part. This patient also had some problems in the left side, a very big aneurysm in the LAD proximal. And for this case, we used the same RevoEdge balloon, both for the circumflex and for the LAD parts. I will not give you all the details for the sake of time. But as you see, we inflated in the proximal part of the LAD. We inflated a stent for the distal part, and we then implanted a left main to LAD stent. And as you see, it was perfectly opened, and we could easily treat this very calcified aneurysmatic LAD lesion. So with the same RevoEdge balloon, we could treat the RCA instant restenosis case and also the LAD very severely calcified and aneurysmatic case. Next case is also another complex case. It's a left main case. It looks like a left main case. And the total occlusion of the PD and the PL, and a severe lesion in the proximal LAD. Of course, we had to do an Ioanes, and we did an Ioanes to check left main because we were not that sure it was an aneurysm of the LAD proximal or it was a lesion of the left main. But the left main was fine. It was more than 10 millimeter square, so we decided to follow the left main medically. But we had to put stent for the LAD proximal part. It was fine, we did that job. But as you see, we had branches of the RCA. The PD and the PL was occluded. Somehow we could cross the PD branch, but we had some dissection there because we had to do some star stuff in that case to cross the proximal parts of the RCA. Yes, PD. Yes, we were in the true lumen distally. We confirmed with the injection, the workhorse wire there. But we had some hematoma that you will see from the images. And we used RevoEdge 2.5 20 millimeter balloon in that purpose to decrease the size of the hematoma. And it helped us a lot. Yeah, the result was not that perfect, but as you know, we can use the cutting balloons for these purposes to decrease the size of the hematoma. And at the end, we had a very good symmetry flow. And for this case, for this indication, we used RevoEdge and it helped us a lot. The next case is another CTO, a double CTO case, RCA CTO and LAD CTO. We started with the LAD one. The LAD was a really complex. It wasn't that long, maybe, but we couldn't see it perfectly from any other waves because it was a very diffusely diseased LAD, as you will see in a few slides later. So we had to go with our feelings. We took a middle-weighted wire, a microcatheter, and luckily we could reach for the distal parts. And we checked with the micro. As you see, we were in the 2 lumen, but the vessel was fully diseased and diffuse diseased, underperfused, very small vessel. In that case, mostly we take a 2O balloon after the microcatheter, then we take our NC balloons or RevoEdge balloon. But for this case, we tried directly 2.5 RevoEdge balloon to test would it cross. And with some small work, it could easily cross the lesion. For proximal part, we inflated, and afterwards, as you see, we stented the proximal part. We just did the DEB for the distal part, and the result was perfect for these diffusely diseased and underperfused vessel, and RevoEdge helped us a lot for this case also. The last case is a bit complex case. The patient had a stent in the ostium of the lady. It was just nailed in the ostium in maybe a few years ago. And also they nailed and stent in the ostium of the intermediate artery. The patient had some left main disease, and the patient had a very severe ostium of proximal of the circumflex disease. So it was a really complex case. What did we do? First, we inflated the ostium of the intermediate artery. We didn't want to lose it. It was a huge branch. And we inflated the proximal circumflex with some balloons. And our plan was to implant a stent from left main circumflex to stabilize that part, because the biggest problem was in the left main, but also in the circumflex, proximal part of the circumflex. We did ballooning, we bring our stent. It was a tortuous, it wasn't so easy, but we could reach that part. We inflated our stent. We did some pods, and also we had to do a kissing for the LAD and the circumflex osteums. And the results was fine. The stent was well opened, the circumflex was fine. But the problem was the ostium of the intermediate artery was not that perfect. We wanted to treat it because it was a really big branch. We didn't want to lose it. What did we do? First, we crossed with 2O balloon, to be honest. It wouldn't be easy to cross it. Then we crossed with 2.5 to 20 millimeter RevoEdge balloon. Actually, we weren't expecting that to cross these struts easily even after 2O balloon, but it did cross. And we inflated the ostium of this intermediate artery. Then we did a direct eluting balloon for the ostium of the intermediate artery. And this is the final result. Sorry, I can show you the next image. Yeah, the last image is not working, which is the most important one. We had a perfect symmetry flow in the intermediate artery. So 2.5 RevoEdge helped us to treat the ostium of this very complex side branches. So in conclusion, I think one of the biggest advantages of the RevoEdge is its crossability. Because with the cutting balloon, we expect to struggle to advance your cutting balloon, but with RevoEdge, we have crossed many lesions, very complex cases with that one. And the cutting elements are, I think they are working. They are opening very complex, very calcified cases. And the size options are also very good. Especially these days, we are dealing with long cases. And if you have long balloons and small balloons, most of the case, maybe you can finish with just DEB. And RevoEdge is helping us to do in that way. Thank you for your attention.
Really a great collection of complex case that you could solve with those blades. I would like to know if any of our colleagues on the panel have some comments at this time.
A very nice collection of cases. I noticed that you used it to decompress a hematoma, and that's something we found cutting balloons and the RevoEdge quite useful for. It's not an uncommon problem in CTO. I'll show a case a bit later on, but also for SCAD, when you have problems and so ongoing symptoms and poor flow, cutting balloon can be very helpful in that situation.
Thank you.
Yeah. I really like this demonstration because we are often thinking about those cutting elements for calcified lesion, fibrotic lesion, but this decompressing of an hematoma is really an issue. And we know that if we take any balloon, just simple, that we are going to inflate, this hematoma is going to progress more distally. We already have to have this fenestration effect, and the decrease in the hematoma is coming from a direct connection between the hematoma that you can see by intravascular imaging very nicely, that is going to be empty and just free in the lumen of the artery, and then you get back a TIMI3 flow. And what I liked also in your case is showing the importance of cutting and then going for not necessarily putting a stent, but using more and more drug-coated balloons. And I don't know, can you share with us the ratio that you will have in your cath lab of drug-coated balloon? And is this changing a lot over the last years? And are these precise tools that we have now to prepare better the lesion really helping to reach perhaps less stent, but also less complication of all these stents?
Yeah, these days, every day, we are using drug-eluting balloons more common. If I'm dealing with branches like I have shown the PD, the PL, the OMs, maybe for the diagonals, these days I'm nearly always using drug-eluting balloons. I replace the stents with them. And also, especially for the bifurcation lesions, I don't remember when I just did my last DK crash. Mostly, I am doing drug-coated cutting balloon for the diagonal. I do a drug-eluting balloon, and if it's fine, I put the stent for the left main, then it's done. And for the branches, yes, I feel completely safe. And moreover, maybe for the ostial lesions, I have done several ostial LAD lesions, especially for CTOs. Because when you are dealing with an ostial CTO, it's not so easy to put a stent because it's for years and years, it's underperfused. And if you put a stent for that part, it will be smaller with the angiography or even with the IOS. But if you inflate it with a drug-eluting balloon, in the future, maybe 6 months later, you will have a better vessel. And if you need to treat it, we can treat it that way. So I'm using drug-eluting balloons in variety of options, and of course, cutting balloon and RevoEdge is helping us to do it that way.
Dr. Hadi, I think that in Malaysia, there are also long diffuse disease vessel, even more than what we can see in Europe, in Sweden, or in Belgium. Can you share with us your experience also of combining those cutting balloons and drug-coated balloons?
Yeah. So in Malaysia itself, our penetration for drug-coated balloon is quite high. At least in my center, is about 50% drug-eluting stent and 50% drug-coated balloons. But there are other centers which their strategy is default with a drug-coated balloon stent as a secondary strategy. So these are very high volume centers which does drug-coated balloons. But my center is 50-50, and nowadays, because of the drug-coated balloons is becoming popular itself, we also need a good lesion preparation in order to make sure that the balloon, the drug itself can be delivered onto the vessel wall. And you need this kind of tools such as a RevoEdge itself to actually cause a dissections in order for the drug to penetrate. In fact, drug-coated balloons is actually indicated for size 3O and below. But I think you're familiar now that more and more data are coming that the role of drug-coated balloons are expanding, and like Dr. Koçaş says, Prof. Koçaş mentioned also, he's using it for complex, in fact for CTOs as well. But we are also using in a large vessel, and I think we are also involved with a study called reverse study where we're looking at the role for drug-coated balloons in large vessel more than 3O and above. So I think drug-coated balloons is becoming more and more popular. It's getting a lot of momentum with the concept of leave nothing behind. But definitely when you want to do a drug-coated balloon, you need to have a very good vessel preparation, and having RevoEdge as part of the armamentarium to address this plaque lesion itself, it's truly a good thing to have in order to have a good lesion prep.
You know, this classification, we started with dissection type A, B, C. Now we are for a very simplistic classification. This is a dissection I don't want to leave and I have to stand, or this is a dissection I can leave, and we don't count anymore all those steps. I really have the impression that by cutting precisely the plaque, we avoid having those very large type E dissection and awful long slow flow. Is it something that you see more often also once you can cut precisely in the plaque?
Yeah. So I think with the presence of scoring and cutting balloon itself, you have a control dissections. So our centers somehow because our default strategy most of the time will be DCB. So we have inclination to use more of a scoring and a cutting balloon. So because in the event that the dissection is really bad, then we go with a bailout stenting. So with using this scoring or cutting balloon itself, it helps to prevent a spiral dissections, and hence our strategy for DCB may be beneficial.
Dr. Ioanes, we would be glad to see what is your experience then in Sweden and in Gothenburg in larger patients, perhaps larger arteries, but I'm sure that you will share with us very interesting case.
Good morning. Let me see if do you see my slides?
Not yet.
Now?
Yes.
Good morning from Sweden. Very interesting cases I've seen. I will try to share you my experience. This is the hospital I work in, the west of Sweden, Sahlgrenska University Hospital. We had the pleasure to use the RevoEdge during the last 4 or 5 months, and now I think everybody's familiar with the balloon, with the design. I think the most interesting thing for me is that the cutting blades are attached proximal and distal, and actually they are free over the balloon. So I think that is a key to increase the flexibility and the deliverability of the balloon. And I will hopefully show this in the cases. These are 3 cases I did during the last months. The first patient is a male, 76-year-old, with a history of cancer, alcohol overconsumption, former smoker. This patient came in the middle of the night with chest pain, echo with anterior hypokinesia, and ejection fraction of 30%. This is the ACG. So you can see the angios severely calcified and very tight left main stenosis. You see some collaterals to the right coronary, which was occluded, chronicle occluded. And this is the IVUS with several parts of circular calcium. Sorry for the low resolution IVUS. This is what we had in the middle of the night. It shows a very, very calcified left main and LAD. So this is we wired the LAD and the circ, and you see the non-compliant balloon. It's not expanding well in the left main. So I went with 3.5 RevoEdge in the proximal LAD and 4.0 with very nice expansion of the balloon. Then you feel confident to put the stents with and post-dilate with a nice result both on angiography, and this is the IVUS of the LAD and the left main. And I want to emphasize in this type of patients, which are, it's emergency, the patient is not actually hemodynamic stable. It is not lying still on the table. You have to do something quick and something that works. So you have all the options. You have options of rotablation or shockwave or something else, but this is very effective, this cutting balloon, and very quick. So I will go to show you the second patient, male, 81 years old, hypertension, unstable angina, presented at another hospital. We did the angiography, showed the 3-vessel disease, ejection fraction of 35%, no significant valvular disease. It was discussed despite his age, but the decision was to the patient refused bypass surgery. And we went for 3-vessel PCI. This is the angiography. You see there is some significant stenosis in the LAD. There is chronic occlusion, a short one of the circ, and very calcified proximal RCA, especially in the ostium, in the proximal part and in the ostium with a large calcium burden. And then the RCA, it's also chronically occluded. So I started with the left coronary. That was no problem. The passage of CTU was done antegrade with a wire, pre-dilatation, stents, and with nice result both on angio and IVUS. Then it remains the right coronary. I did some pre-dilatation of the proximal with a 2.5 balloon, and this is the IVUS after that. And you see the very, very, very calcified proximal part, and yep, then it's running again. The RCA was opened retrogradely to that large epicardial collateral from the LAD. We passed true to true, as the IVUS will show later, and you see this dilatations, repeated dilatations in the proximal part and in the ostium with RevoEdge 3.5 and 4.0 with nice expansion of the balloon. We did the IVUS afterwards, and we were confident to go ahead with the stents. This is the angiograph, final angio, and this is the IVUS, very nice lumen, nice expansion of the stents. All the way, you will see to the aorta. Just in a second. Over there. Yeah. So the third case, 75 years old male, history of diabetes, a stroke, chronic catheter, and due to this repeated urosepsis, presents with pulmonary edema, non-STEMI at another hospital. Echo with poor ejection fraction, inferior akinesia, no significant valvular disease. As expected, a coronary angiography with the 3-vessel disease. We discussed it also, and was turned down for surgery and accepted for PCI. This is the angio. We aim to revascularize the left main, the LAD, and the circ. There was no viability in the inferior wall, so we left the right coronary. Again, you have all the options here. You can go with rotablation of the LAD. In the mid part, it's very heavy calcified. The left main is also calcified, but the problem here would be that you maybe lose the proximal part of the CTU, and the circ is important for this patient. So I put a wire in the, this is just another picture of the angio, and you see the collaterals from the right coronary to the circ. So I choose to put a wire, a workhorse wire in the LAD, and open the the CTU in the circ. And once you have two wires, the rotablation will be somehow problematic. So the left main, this is the IVUS of some pictures of the IVUS in the left main and the LAD. You see almost circular calcium, very heavy calcified. So the LAD and the left main was prepared only with RevoEdge. From 3.0 here up to 3.5 and 4.0 in the left main, with nice expansion of the balloons. Then I went to the circ, and one of the very nice things that I actually could reuse the 3.5 4.0 balloon RevoEdge, which I used in the LAD to dilate the proximal circ, which is not a usual thing with other cutting or scoring balloons. Once you use them, you have to get another one if you want to reuse it. As one of my colleagues just said in one of the previous presentations, repeated inflations of the cutting balloon, the so-called Rodin technique, which is very nice, described by one of my friends from Belgium. And this helped very well. In the osteal circ, we had to do also some shockwave to get a better expansion of the balloons. And this is the final result with the stents in both LAD, left main, and the proximal circ. And this is the final Ioanes from LAD back to the left main. Also here, a nice stent expansion and a good area. There is, you see the calcium behind the stents there, it's still there, but the stent area was very good at all the levels. I will just let this one play all the way to left main, and there we are. Oh, it's playing again. So as everybody recognized, the calcified lesions are one of our greatest challenge in PCI, and I think that RevoEdge cutting balloon, it's a welcome new addition to all this arsenal of devices we have to use to prepare these lesions. And in our cases, this new balloon was proved to be effective, easy to deliver, reuse several times in several vessels, and with a good effect of the on the calcifications. Thank you.
Very nice collection of difficult case. I like the one with the left main, because if you have to choose between lithotripsy or if you have to just go with the inflation of blades, I think the patient has some problems with a long lithotripsy procedure in the left main.
Yes, I think you're referring to the first case.
Yes.
It's important to. It's important to do something quick. You have to keep in mind that this is a patient which is hemodynamically unstable. It's in the middle of the night. He's not lying still. So the cutting balloon worked very, very well. And as you said, putting a shock wave here for it will not help the hemodynamic status of the patient.
Nor the physician on board at 2 a.m. And any comments from the panel?
Thank you, Dr. Denos, for complex and perfect cases. Also, the last case was very complex. The ejection fraction was low. It was so calcified. You did have just one main branch there. So without the help of the RevoEdge, it would be so complex. I would just ask, would you consider using mechanical circulatory support for the last case? Because the right was occluded, the circumflex was occluded. You just had an LAD, and you were dealing with a very calcified lesions. In Turkey, we cannot reach mechanical circulatory support easily. So we cannot use it, but I guess you can reach it there.
Yes, it's it's a problem in Sweden also. It depends on different hospitals. In our hospitals, we have a very nice program with ECMO. We actually don't have Impella. We are working on it, but it costs money, and we thought that ECMO will be maybe too much for this patient. We did some cases with ECMO on standby. So we just put 6 French sheets. We have the ECMO machine on the cath lab prepare, and we use it if we need it. But this was done without. But I totally agree with you. In a perfect world, that would be a case with Impella support.
If there are no other burning questions, I think it's time for Professor Scott Harding to share with us his experience from New Zealand. It's really a pleasure to have you on board this seminar. You are on mute, Professor Harding.
Sorry. So you should be able to see my screen here.
Yes.
Okay. I sort of knew that quite a few people were presenting for me and would go over the balloon and the details. And it's a great pleasure to be part of this webinar. And I'm just going to show you a quick potpourri of cases that we've used the RevoEdge with recently. Because I do really think this is a versatile device with multiple potential applications. So this is a 62-year-old who presented with recurrent angina only 4 months after stenting of the LAD in another hospital. Had a background of type 2 diabetes mellitus, and you can see there's a tight restenosis in the LAD stent, and there's a diagonal branch involved. That diagonal was not stented. So we pre-dilated, and as we do for all ISR, we would image. So this is an OCT, and what the OCT, this is at the level of the side branch, showed is that the stent was somewhat undersized. So the expansion was only about 2.5 millimeters, and also there was near-intimal hyperplasia. A little bit further down, the stent's still undersized, and there is near-intimal hyperplasia. Remember, we've already ballooned this with a 2.0 balloon. So this is a perfect case for RevoEdge. And again, this is where I think the high pressure is really valuable. So 3.0 RevoEdge in the LAD obviously made multiple inflations up to 20 atmospheres. A little bit further down, there's also restenosis, high pressure inflations. And then again, this is one of the nice things about the crossability. We're able to cross into the side branch through the stent with a 2.5 RevoEdge balloon, and then dilate the origin of that diagonal. This is the OCT, just to check the preparation following the dilatation with the RevoEdge. So we've only dilated with the RevoEdge, and you can see we've managed to expand the stent considerably compared to what it was. You can see the sort of cuts that you get with the RevoEdge, and you can see that we've got quite a big lumen. Again, you can clearly see the cuts that we've achieved in the near intima with the RevoEdge. And so we're pretty happy with that preparation. So then DCB to the distal, DCB kissing into the proximal LAD and the diagonal. And this is the final result, which I think was pretty reasonable. And the patients remained asymptomatic after 6 months. Another case, so this is a 71-year-old with the CTO of the OM, which looked very straightforward. So very short. I guess the tricky part about it is that there's tortuosity leading into the CTO. So this is just an XTA. XTA goes, we're pretty happy, but then just not feeling quite right. Looks as though maybe okay distally. It's a bit hard to tell, but this is the IVUS. So clearly we are subintimal, and we're subintimal right from the get-go, in fact. And so what we had to do is do rewiring under direct visualization. So this is to have the IVUS down, rewiring, and managed to rewire the true lumen, but then we have this problem. So we're in the true lumen, but we have this massive hematoma. So if we try and just put a stent in here or just balloon this, we'll just push this hematoma downstream and we'll have no flow. So RevoEdge cutting to decompress this hematoma, stenting, and you can see by decompressing the hematoma first, we've managed to achieve a good result. So I think this has been very useful. We've done in some SCAD cases, which has been very useful. Another case, 59-year-old presenting with non-STEMI, had this sort of bifurcation. You have involvement of this OM and then in the sort of main circumflex. Clearly, we want to try and keep this simple, so we cut the side branch, cut the main branch, DCB the side branch, and then stent a limited section in the main branch to achieve this result. So again, I think this is, there's a lot of data emerging that particularly by treating the side branch with DCB following preparation, we can avoid two-stent strategies and we can improve outcomes. So another case, 76-year-old with angina, previous CABG. The SVG to RSA had failed. It was getting a lot of angina. They had the CTO of the RSA, sort of long and sort of complex. Was crossed using reverse cart. And then we put a stent in distally and then used the stent balloon to inflate proximally. And you can see that there's an area of under expansion. Obviously it's a stent balloon, it's long, but this is up at 18 atmospheres. This is the IVUS following the balloon inflation. It's a little bit hard to see because there's actually 3 wires in here. So there's a lot of wire shadowing here and wire shadow here, but there's about 270 degrees of calcium. And again, this is the RevoEdge, dilates very nicely. And then we can stent, and you can see at that level, we've got really good expansion. You can see here, this is where the calcium's fractured, allowing expansion of the stent in a big MSA. So that's the final result there. So I just wanted to show you a sort of little potpourri of cases. We've used this in a variety of indications. I think it's great for treatment of ISR, preparation of de novo lesions for DCB, if we've already seen tonight. You saw a lot of calcified cases being treated, and certainly some cases where I would have thought you were pushing the envelope, but maybe I should be pushing it a bit more. And also, I think for decompression of hematoma, either in the CTO or SCAD, it can be very useful. So thank you.
Very interesting. And I was also glad to see a beautiful OCT image that we can also use to better assess the calcium. And I was wondering, what is your experience in those specific nodular lesions with OCT that you can see better?
Yeah, so as I say, we do a lot of imaging. For me, I image every case. Our lab overall does images about 65% of all cases, and that's about 1/3 OCT and about 2/3 IVUS. I think OCT does have some advantages in heavily calcified lesions, and particularly the thickness, which can be difficult to interpret all on IVUS, and certainly for for nodular lesions gives you very good definition. I think what we've learned about nodular lesions is that actually eruptive nodular lesions are actually quite deformable and don't need lithotripsy. They don't need atherectomy in a lot of cases and can be treated with either balloons or cutting balloons or scoring balloons. The sort of non-eruptive nodules are a different beast. And I think, you know, it really depends. I am a little reticent to use cutting balloons when we have a big eccentric non-eruptive nodule. And the reason is that the main way we get expansion is by expanding the adventitia, and we could potentially cut, you know, into the normal vessel, and maybe we're more likely to get a perforation. I don't know, but I would be a little bit reticent for big non-eruptive calcium nodules to use a cutting pressure, a balloon at high pressure, because I think that may increase your risk of perforation. So that may be one indication that's not great for.
I agree. Any comments from the panel?
Thank you, Dr. Harding, for this excellent presentation. My question is, of course, the size of the RevoEdge and the other cutting balloons are very important, the sizing. You must choose you must decide the right size. And as I see, you do a lot of OCT or RIVOS. Do you use one-to-one size according to OCT, or you downsize the cutting balloon?
It depends on the indication. So the problem, if you're trying to decompress a hematoma, if you undersize it, you don't fenestrate. That's the problem. And so usually you don't have to go to high pressure to fenestrate. So usually I would go at least 1-to-1 with a distal vessel, and you know, sort of go to sort of, you know, 8 atmospheres, 10 atmospheres, something like that, because what we're just trying to do is make sure that we fenestrate. So undersizing is a real problem there. If the calcium's more eccentric, I'm a little bit more conservative around my sizing. Within a stent, within you know, concentric calcium, I think you can be aggressive. So certainly 1-to-1 sizing within a stent. You know, if the stent's undersized, then we really want to make sure that we size it, you know, 1-to-1. So I have no problem in those settings.
Sorry for the background noise. This is live from the cath lab.
Experience using the cutting balloon and SCAD? Because we found that quite good. I mean, clearly there's a lot of SCAD that comes to the lab that we don't need to intervene on. But there is cases, people coming with STEMI, they've got no flow down the artery. There's extensive hematoma in the vessel. And we've actually found this be quite good. And there's been some publications from Europe, you know, the cuttering technique, etc., which suggests that this is quite a useful technique. Anyone else have experience?
Yes, I had similar cases with SCAD with large hematoma in the proximal LAD, and you learn the hard way. You dilate, the LAD, and the hematoma moves to the circ, and then the patient gets unstable. So then we did a cutting balloon to relieve the hematoma. But those are scary cases, really.
I've not had much of a SCAD case where I work, apart from probably intentionally dissections, and then my fellows would continuously inject. Probably that's kind of cases which I have, but SCAD cases is something which I don't often encounter. But I think you can see that RevoEdge is a tool that you can use to address this kind of problems.
I think the biggest problem with this cut is you don't understand its cuts in most scenarios. You have a closed artery, you don't know. Only if you have some clues from the clinic, a young woman or a young man. And so mostly you cannot be sure it's a cut. But with the help of the RevoEdge, you can cross it easily. Maybe you will feel safe with it. And maybe you can use the use of the cutting balloons, decrease the threshold to use the cutting balloons. If you have any suspicion about the cut, maybe you should directly start with the RevoEdge, and you can use it as an NC balloon. And if it is a cut, and if you have any suspicion about the cut, then you will have the flow maybe. Yeah, it's the problem with the cut.
Yeah, I think the thing about SCAD is often there's a lot of clues, right? Young woman, no risk factors. They often have had tortuous vessels, and you can't see any other evidence of atherosclerosis in any other arteries, and there's an occlusion. It's almost always SCAD. I think the key for me is that, what we do is we try to wire these vessels. And actually we use the CO03 for this because it's very floppy. And again, there's some publication from Europe for this, because if it's going in the true lumen, it usually goes very quickly. If it's in the subintimal space, or it will just fold very easy. So it's quite a nice way of testing whether you're in the true lumen or not. Once we wire it, we put the IVUS down, because it's very important. If you're in the true lumen and you've got hematoma, then cutting is very effective. If you're in the false lumen, then there's not really cutting that you need. You need to get back into the true lumen. So you either have to rewire in the true lumen and then cut it, or in some cases, if you can't rewire into a lumen, then basically you have to star it out the bottom to basically decompress it that way. So I think it is quite important really to understand the position of the wire to try and work out whether, cutting is the right strategy or not. Because you inflate a cutting balloon and you're in the subintimal space, then you won't fenestrate the true lumen.
Indeed. And those are the cases where you can get some complications. I don't know, at this level, we cannot say that any balloon is 100% perfect. In the few that I have used, I had only one case of a balloon that perforated by some nodule of calcium, but I think that's a very robust balloon that resists most of these very calcified lesions. Any other concern that you want to share from the panel on the safety? Have you seen problems, tips and tricks that you want to share for the last 5 minutes?
If you are using a second wire, like our case, the PD, the PL, if you are using the RevoEdge, you should be cautious, like all the cutting balloons, the wires can twist. I think it's important. And for most of the guide extension catheters, I think it's compatible. We have tried it, but if you are using 3.5 or maybe 4, or you should check it if it's compatible with your guide extension, because most of the times you need guide extensions for these calcified long lesions. So if you use it and if you have 6 French one, maybe you should check it if it's compatible. These are the points, I think.
I think that's quite different between the lumen size of different guide catheters, right? So the Guidezilla has quite a small internal lumen. I doubt very much that you get a 4.0 RevoEdge down that, whereas the liquid, for example, has a very large internal diameter. In fact, you can get a 4.0 shockwave down that. So it will be very guide catheter dependent, guide catheter extension dependent.
I think sorry, Dr.
Sorry. Just one thing. I usually, when I see this large amount of calcium which I have to treat, I go straight forward for the 7 French guide, and in most cases it works well through the radial approach, and then I think it's a big advantage to have all other backup, a lot more space to deal in the guiding catheter, and it can be done even in emergency. So I think all the cases I show were done with 7 French guides.
I'll just add on a little bit more. Just going to the RevoEdge balloon itself. I think just to highlight that it has multiple lengths and multiple sizes, even to the 1.5. So I think this is one of the advantages of the RevoEdge in terms of addressing and then maneuvering yourself to a very tortuous or difficult lesion. So this is the benefit of using the RevoEdge in terms of calcified lesions. Yeah.
And maybe a tip for the audience, you should inflate it slowly, of course, like for a cutting balloon. You should not directly just go to 10 atmospheres. You should go for 4, wait for a while, then inflate it slowly and slowly. Going directly up to very high pressures may cause ruptures or other problems. You should inflate it slowly.
So I think that we are close to the end of this webinar. That was really nicely put together by the company Brosmet, and I thank them again for this. And as a short summary, I would say that there are as many of these algorithms to treat calcified lesion than there are different balloons to treat them. But everywhere you will find a well-defined spot for those cutting and scoring balloons. And this is often said that it is at the time where you will have some deep calcium, important 3/4 of calcium with some intravascular imaging. And this is what you have to recognize. And we have to admit that sometimes it will not be so easy to imagine, and we still have the coronary angiogram to perform our job. And you see that we were talking about nodular calcium. I was just taking this very last example. You have all the criteria to make your choice, but sometimes you can just not go for this kind of imaging, and you have to rely on your angiogram. And you see that now with a device like the RevoEdge that has a better profile than even the imaging catheter, we can prepare the lesions. And we have seen finally from all the colleagues on the panel that we are treating calcified lesion, we are treating in-central stenosis, we are treating hematoma. We have a very important new tool in our armamentarium, and this is really with an excellent crossing profile, these 3 blades that are helping us in our complex case and in multivessel disease. I thank you all once again for taking part of this very excellent webinar. Have a great day and a great evening in New Zealand.
Thank you. Bye-bye.
Thank you.
Thank you.